Hi, everyone. I'm Taylor Abel. I'm a neurosurgeon at UPMC Children's Hospital of Pittsburgh, and my practice focuses on epilepsy. And I'm going to be talking about the best surgical strategies for Lennox-Gastaut Syndrome. I'm specifically going to be talking about comparisons of vagus nerve stimulation in Corpus callosotomy because other people are talking about other things today. And I just want to start with a story. So as an epilepsy surgeon, this is something I've always been interested in, but this work actually started when I was in a meeting with hospital administrators. And these meetings, for those of you that are surgeons or even neurologists, probably happen a lot, where the administrators will talk to you about how much money the hospital loses from vagus nerve stimulator implantations. And as a surgeon, I feel a bit out of my depth in these meetings, and so it prompted me to take a cost effectiveness class. And that prompted me to take a decision analytic modeling class. And then I ended up taking a programming class. And now I'm halfway through a PhD that focuses on health economics that I've been using to apply to understanding the best epilepsy surgery strategies. So my background is actually I'm an auditory cognitive neuroscientist that does epilepsy surgery, but I've really started to move my lab in this different direction, and I'm going to show you some of that preliminary work today. So Sandy's talk was really important because the models I'm going to show you, we don't have great data inputs for. And the reason we don't have great data inputs for them is because there's a lack of prospective and retrospective, high-quality retrospective studies that have generated data to actually show us what we need to put in these models. These are my funding disclosures. Epilepsy surgery and Lennox-Gastaut syndrome. We don't have curative treatments for Lennox-Gastaut, and surgical treatments are palliative. They're aimed at reducing seizure burden and improving quality of life. I think we all know this. There are several surgical options for children with LGS, but these options have limited evidence to guide them, like we've just talked about. Further, the available treatments differ in multiple dimensions. Some of them are more effective than others. Some of them cost different things. They have very different complication profiles. We need ways to understand outcomes holistically in order to help families make shared decisions about what's best for their loved ones. This is just a summary of the different options that are available. Does my mouse work? Yes. So this is an example of a corpus callosotomy, and I'll be comparing that with VNS, which is depicted here. But we also have RNS, which Dr. Morell will be talking about later, and DBS, which we'll also have a talk on later. So probably the main meta-analysis that has compared vagus nerve stimulation with corpus callosotomy for seizures in Lennox-Gastaut is this Lankman study. And essentially what this showed is that if you're comparing these two strategies, really focusing on seizure control, because quality of life is not something we have great comparative data for these two surgeries, corpus callosotomy is more effective if you were to pool all the seizure types together overall, and much more effective for atonic seizures. So it's about 50% free of atonic seizures for corpus callosotomy compared to about 20% for vagus nerve stimulation. And so there's a very big difference in the effectiveness of these two procedures. And this is a meta-analysis from George Ibrahim's group that essentially shows a very similar result, but focusing exclusively on atonic seizures, that if you're looking at the effectiveness, corpus callosotomy is more effective for atonic seizures compared to vagus nerve stimulation. Now that said, we all know that vagus nerve stimulation has it's a very different surgery with a very different complication profile. And so part of the problem with comparing these two modalities, and for families who are trying to make decisions, is that the comparisons are not unidimensional. Like we just talked about, the effectiveness differs considerably, but also the complication rates differ as well. Further, we really don't have great utilities data, meaning we don't really know what the value of these surgeries are for families if we're looking at outcomes at 1 year or 2 years, or especially even further down the road. And so for those reasons, I use an economic model to compare those two strategies, and I'll show you some of our preliminary work. These models, and actually I'll just show you the model here. And so what these models do is it takes an average patient with Lennox-Gastaut syndrome and compares two different strategies. In this situation, vagus nerve stimulation or corpus callosotomy. And then once you make that decision, then there's another branch in this tree that takes you to whether it's effective or not and whether you had a complication or not. If you have a serious complication, like an infection that requires an additional surgery and removing the VNS, I don't consider you to have an effective outcome. If your seizures don't get better in a meaningful way as defined by these meta-analyses, which are our model inputs, then I also don't consider that to be an effective procedure. So typically these economic models consider quality of life utilities, so you can actually assign like a QALY and use QALYs to determine the actual value of your outcome. But since we don't have that data, I just consider a binary outcome. You either had benefit from the procedure, meaning your seizures got better and you didn't have a complication, or you don't. So this is a very coarse model, but this is a preliminary model, and we hope to build on this in the future. And so I was surprised to find that if you, especially given my discussions with the hospital administrators, that if you look at a 1-year time horizon, this means we're not considering battery changes from vagus nerve stimulation. Vagus nerve stimulation is the most cost-effective strategy, and the incremental cost-effectiveness ratio, meaning the added amount of money that you'd pay per incremental benefit for a corpus callosotomy, is about $500,000. And probably what drives that is the dramatic difference in the hospitalization stay in the acute period between a corpus callosotomy and a vagus nerve stimulator. And so the model I'm working on right now is a much more complicated model that incorporates battery changes into that modeling. And so things will change a lot when you start looking at a 25 to 50 year time horizon, where every 3 to 8 years, patients are getting battery changes, because that will change the cost a lot. But if you're looking at just 1 year, vagus nerve stimulation, even though it is less effective, a probability of 0.48 versus a probability of 0.63 of effectiveness, vagus nerve stimulation is more cost effective. Now, this model also considers all seizures pooled together. And so I'm considering all seizure types pooled from these meta-analyses. I do what's called a situational sensitivity analysis, where I change the model outcome and make it only atonic seizures or drop attacks. And if you change the model that way, corpus callosotomy is much more effective. It's now has a probability of 0.8 compared to 0.53, but the incremental cost effectiveness ratio is now half of what it was with the previous model. And so this work's ongoing, but there are other strategies that other people are going to talk about today, and I won't spend more time talking about it. The ESTIL trial for DBS and the ongoing trial for RNS are both very exciting. We need to understand what the value of these procedures are for patients. And so one thing we're doing right now in preparation for a larger, hopefully prospective study, is we have a survey that went out about a month ago, and about 85% of families have, 85 families have responded so far. But what we're trying to understand is what a meaningful outcome is for families that have these surgeries. And we need to know what that is so that we can do a power analysis to write a bigger grant, because there's no way we're going to be able to do this kind of study under $500,000 a year, because we'll need multiple sites and we'll need to coordinate a lot of people together. And so, and the other thing we have to prove to NIH is that we can't do a randomized controlled trial. There's no way families will go for that. And our preliminary data is only about 9% of families would ever agree to that. These procedures are so different that you just couldn't do that. Conclusions: we need large multi-center comparative effectiveness studies like the one that Dr. Lamb is spearheading. And we need to think about more than just seizure control. We need to think about quality of life, what the value of these procedures actually are for families. We need to think about developing treatments that not only are effective for seizure control, but are actually going to modify the course of these illnesses. And seizure control is important, but cost is also important. These are rare diseases, but if you're like me, you see 3 or 4 patients every clinic who have Lennox-Gastaut syndrome. And it's important to consider the ratio of effectiveness to morbidity with these procedures. I don't know where I'm at with time, but that's my talk. Okay. I was so focused I couldn't hear it. All right.
Now we're on. Okay. Hey, Taylor, Jim Wheelis. Good to see you. You didn't get the memo about wearing black, but anyhow.
Well, I was on call last night and I had an early flight. I was planning on wearing a black suit, but instead I wore a black vest.
Okay. Anyhow, so I'd like it conceptually. What I don't understand is if all of our treatments are palliative, why are we getting into this one or the other, kind of discussion? Because if someone goes from 200 drops a month to 100, the logical thing is if I can add in another palliative and they go to 15 or 10, they're still better off. I've never had a family that said like, oh, we're happy, we dropped 50%, I'm good. I mean, they all would like to have fewer. So I don't understand, the and/or concept. I do like the idea of, okay, they're different and they may have different effects. They may have different seizure types. They may have different effects on alertness and other stuff. But otherwise, I think we shoot ourselves in the foot when we play this. It's one or the other game because our colleagues look at that and go, oh, I can only do this or this. And it's like, no, you can do both. You have a whole armamentarium. Use it.
I think that's a really great point. And first of all, the reason we used a binary outcome for the purpose of this model is just this is a preliminary model, and we have to develop better metrics for defining value. But you're absolutely right. If we ever do a prospective study, the biggest challenge is going to be dealing with crossover between groups. Because when we look at our data, 60% of patients that have a callosotomy already have a VNS. And getting a callosotomy first, we do it for kids that have really severe drop attacks, where that's their main issue. But a lot of times I put a VNS in at the same time, because I know they're going to need one eventually, and that's what our group agrees on. And so, and when we do a bigger study or more complex models, these may have to be treated as distinct strategies. So VNS and callosotomy maybe need to be treated together, or VNS and DBS, different combinations, and we just need to develop ways of modeling these different strategies.